My name is John Zaffer, and I'm the Senior Acquisitions Editor at Springer Publishing. For those of you who don't know Springer Publishing, we are an award-winning publisher of nursing and healthcare content, featuring books, apps, journals, and digital products. Today, we are pleased to be presenting a case-based approach to common complaints, featuring James Van Ree, Christine Bruce, and Stephanie Neri. James Van Ree is the Program Director for the Yale University School of Medicine Physician Assistant Online Program. Christine Bruce is an Associate Professor and the Program Director of the Penn State University Physician Assistant Program. Stephanie Neri is an Assistant Professor Adjunct at the Yale School of Medicine Physician Assistant Online Program. And without further ado, we're going to turn the time over to our presenters. Take it away, guys.
Okay, well, thank you, John. Welcome, everybody. As he mentioned, my name is Jim Van Ree. I'm the Program Director for the Yale Online PA Program. And I'm going to be the first presenter here, and then my colleagues will follow. And what we're going to do here is kind of present to you how you can use some of the tools from the Clinical Medicine for PAs book, the textbook, the cases we've developed, and the test item bank to help deliver clinical medicine courses to your program. So let me get started here. So one of the ways that I like to do this is a lot of people like to use case-based. I also do a lot of problem-based learning in my program. So using this to try to get students to apply the material. It's one thing to have them rote memorize, but it's another thing to have them actually apply the material. So I use a lot of cases. And this is an example of one of them actually that's in the book and that I've used over the years. So we have a 50-year-old male presents to the family practice clinic complaining of fatigue for the last 4 to 5 months. Usually what I do then with students is I ask them for their differential diagnosis. The reason being is starting with a differential before, I know they always want to ask questions, well, what about this? What about that? Do they smoke? Do they do this? What directs our questions and directs our physical exam and directs our laboratory testing is what we think is wrong with the patient. So we would spend some time going through all of these differentials with the student, and these are all laid out in the book. So this could be infectious causes, it could be anemia, it could be endocrine disorders, kind of giving it away that it's probably anemia since I'm the hematology person. Could be sleep disorders, could be medication, malignancies, and so on. So getting the students to think through all the etiologies, and this can be really difficult at times because students don't want to be wrong. They want to come up with the correct answer right away, even though there's not near enough information here for them to come up with the right answer. Then what we would do is have them go through the history of present illness. Now, you could have them work through that one question at a time. You could feed them the information. A lot of times I'll give them the full HPI. So they've been noticing increased fatigue for the last 4 to 5 months. Steady exercises every day, but has been noticing some shortness of breath while exercising. Denies any orthopnea, paroxysmal nocturnal dyspnea or ankle edema. Denies any change in his bowels, melanor, bright red blood per rectum. Has noted some vague left-sided abdominal pain on and off. No history of fevers, chills, nausea, vomiting, and has lost 5 pounds over the last few months that he relates to dieting and exercise. So now that they've gotten a little bit of history, and we could have gone into more detail with family history, social history, but now that they have this and they have their differential, one of the things I like to ask them is, well, what do you want to do for physical exam? What do you want to examine? Do you want to get a set of vital signs? Do you want to get a general exam? Do you want to get heart exam, cardiac exam, lung exam? And then you slowly unload this material to them. So they get the vital signs and they can go through those. They see these are well-developed, well-nourished white male, appears his stated age. And then you can give them the rest of the exam based on what they asked for. Now, if you direct this as a discussion, which is the way I like to do it, I don't let them see everything if they didn't ask for it. Because in real life, if you didn't examine or ask a patient, you wouldn't get that information. So I kind of make the students utilize this as an opportunity to say why they want to get certain things. Why do you want to look in the throat? Why do you want to feel the neck? Why do you want to listen to the lungs? And then they can then discuss on how this information then applies. So as you can see here, for example, this person has a 2/6 systolic ejection murmur without gallops or clicks. So then you could explain to the students or discuss with the students why this is important. How does this relate back? Get them to understand how this relates back to your differential diagnosis, always using that differential diagnosis and going back to it as often as you want to try to revisit. Maybe you cross some things off your list now, maybe you add new things. This also then can help direct them what they want to do for laboratory testing. So often ask, what laboratory studies would you like to obtain? And once again, when they give you a lab, the way these cases are laid out is you have the opportunity to ask, why do you want that lab? They should have a rationale. One of my favorite reasons they always give is because that's what the book says. Well, that's not real life, okay? We need to understand why you're doing what you're doing. So in this case, you might have ordered a CBC. And all of these results are available in the book. And one of the things you can then go through with them is, how do you interpret this CBC? What do you see as a result of that? When you looked at those numbers, what do you get? And have them actually explain to you that what you see is a low hemoglobin indicating there's an anemia. And when they analyze the indices, the MCV, MCHC, and MCH, they see that it's a microcytic hyperchromic anemia. And now that they've had some history, some physical exam, and some labs, now you get them to revisit their differential and see how you can take this information and apply it to their first differential. So now the differential, now that they know we have a microcytic hyperchromic anemia, we can now have them think through, what are the causes of that? We talk about iron deficiency, talk about thalassemia, sideroblastic anemia, even anemia of chronic disease. I suppose we could add lead poisoning to this as well, though it would be kind of unusual for a man of this age. But all of this content then could have been assigned readings ahead of time or after the fact when you finish the case out of the textbook. And then the most important thing, and the thing that students I know struggle with over time the most, is what about follow-up tests and what about treatment? You know, what do you do next? They always, how do I got the diagnosis, but what do I do for this patient now? So you could do other laboratory tests, okay? And they'll be available. What reticulocyte count? You can get iron studies. You can get all the iron studies. You can get a ferritin. And now you can have all of this information and finally come up with the final diagnosis. So based on these iron studies, the most likely diagnosis is iron deficiency anemia. This is consistent with the low retic count, the low serum iron, the elevated TIBC, and the low serum ferritin. Now you can run these cases a couple of different ways. I've kind of been vague. Some of my colleagues that follow up are going to be a little more detailed in their slide, because I wanted to show the way where you could present and use these cases where the discussion is really driven by the students, where you ask them the questions, more of a problem-based approach where you ask them the questions. What does a low iron mean? What does a low TIBC or high TIBC mean? What does a low ferritin mean? And how do you apply that back to the differential? And then you can tie this all in together with just a quick review of the anemias. This could be an assignment afterwards. This could be something then you lead into as a lecture, where you could start talking about the classifications, looking at iron deficiency, thalassemia, all the things we just discussed as part of our differential. And we've got a number of slides, photographs that are available both in the instructor's manual and in the textbook to utilize for these cases. You can even go so far as to discuss all the different types of anemias, the normocytic anemias, the hemolytics, the blood loss, the chronic disease, and even the macrocytic anemias. Now, one of the other interesting things that we did is we looked at, and why this presentation was called Approach to Common Presentations or Common Symptoms, is at the end of each of the chapters, we've created either flowcharts, algorithms, a number of devices we've created to help students and to help you present to students the approach to these problems. Giving them a lecture on anemias is great, giving them all the information, but then how do you teach the students how to approach somebody who does have anemia? That's what we're trying to get here. So my approach here was to kind of be a little more less detailed with the information, where you could then see how this discussion could just kind of flow when you're doing this with either a small group, it works with a large group of students as well, but how presenting them with limited information, requiring that they do the thinking, they do the thought process, they think through and develop those diagnostic reasoning, diagnostic thinking skills, with working through just with the information they ask for, not giving them anything else. So this is just one approach to using the cases in the book, one approach to using the flow charts that are in the book, the photographs, the content that's in there, and be able to apply it in different ways. It's not just presenting a lecture, though we've got a lot of presentation slides that instructors can use to do their lectures. There's lots of other ways to utilize this information other than just doing a run-of-the-mill in front of a large group lecture. So now I'm going to turn it over to Chris Bruce, who's going to look at it from a little bit different way.
Oh, thank you, Jim. So another way of looking or utilizing the book would be to actually use the slide decks that occur for every chapter. So if you're going to be doing a cardiology review, there is a very detailed slide deck that talks about everything from hypertension, congenital heart disease, chronic heart failure, acute coronary syndrome, all of the cardiomyopathies. And you could assign that slide deck for an overview or a review before an exam, or actually do something like a team-based learning presentation as a result of that slide deck. So the slide decks are going to be, I don't see textbooks that actually have PowerPoint slides that accompany it, nor do I see textbooks that have an accompanying test bank that is secure to you and your facility alone. These are not test questions that are available that the students could get to. So we would ask that you keep them secure. You could have them loaded onto your learning management system and pick and choose what you're teaching to have 1,000 questions already made for you that would really help. You could use them for end of rotation exams. You could use them for part of the clinical medicine. They're going to be yours to use. So a way that I like to use a presentation, and this is one of the cases, there's an approach to a patient with chest pain. There's also approaches with abdominal pain. And so it's going to be a very similar situation where you're going to have the presenting signs and symptoms. I like to have the students drive what is being talked about. And like Jim, I also, if they want to order a test, they're able to order the test as long as they can justify, and as long as the results of the test are going to change what you're going to do for the patient. And then you can actually bring in imaging. For this particular example, I brought in some EKGs, and then we can talk about what would you need to consider, what's your differential diagnosis, what's your working diagnosis, and what's your treatment approach. So here is our patient that's coming into the office, and just a clue about he's having some chest pain. And I'm going to give you the physical exam just to consider whenever I'm going to go into the detail. So I want you to not get distracted at the point with his history, but take a look at his physical exam. And the nice part of this is that you can go back and review these findings and say, wow, he has a grade 2 over systolic ejection murmur. Look back in his chart, and you as the facilitator, you could say, this is a new murmur. This is one of your patients. You've seen him before. He did not have this murmur before. How does that change your approach, or what could the significance of that murmur be? So there are things that are going to be teased out that you could really use to deepen the learning, and depending on where they are. So now here is his history, and the history is going to drive some of your differential diagnosis. He's having some exertional chest pain. He was out golfing. He is diaphoretic. And, that might be something that, if you say to the students when you go over this case, and you could even be that patient and have them interview you. And that's another way of honing their history and physical exam skills. Like Jim said, the physical exam, this is what it's linked to, but you could ask them to say, okay, I'm a 69-year-old male with chest pain. This is your patient. That's what the entry is on his chart. And now you have to go and get the information from him. And then you could show them the slide afterwards to say, okay, this is where he is. This is what you needed to find out. What did we miss? What important elements should we have asked that we didn't? And then I'm bringing in his past medical history. How does that influence his likelihood of having an acute coronary event? And also, what about his family history? And I think that could be very important and very relevant to the patient's presentation. So with the next slide, we're going to then go in to say, what would we want to add, or what labs? And some labs you can get back immediately. Other labs are going to be coming back a little bit later. And then you can also talk about the new high sensitivity troponin levels. What's the new protocol? The timing has changed with the ultrasensitive troponin level. And so what is the protocol at the facility that you're practicing at? What is another teaching point you could use is his BNP is rather low. So it doesn't look like he has overt heart failure. It's a little bit above normal, but I also gave you that he was obese. And how does obesity affect the BNP? So these are all additional learning tools that you could add to the case. And remember, if these students are second-year students out on clinical rotations, you could really go much more in depth than your students just starting the program. And then how do you stabilize the patient? What are the initial things that you're going to be doing for the patient? Once again, teaching points. I gave you his oxygen level, his oxygen saturation level. And, everybody wants to put oxygen on a patient that's having chest pain. Well, now we know that it is not needed for every patient. And so I have that if you said oxygen, that's not something he would need to do. And then also early on, you have enough information. I'm going to give you the EKG coming up. And is this the point we get cardiology consulted, or do we even call a cath lab at this point? So this would be a nice point that you could review his EKG. You could talk about, I gave him a pulse of 100. This EKG has a heart rate of 100. You could talk about the significant findings. And then that's going to drive your decision point moving forward on what are we going to do for this patient. So what do we not want to miss? What are the urgent considerations? And it is broad based on the cardiovascular system. And each of these could be a minimal, a 1 or 2 sentence discussing, do you remember what Takotsubo cardiomyopathy is? Is he a person that is at risk? What about Brugada syndrome? Is he at risk for this? Because these are life-threatening conditions. They're rare, but is he in the right patient profile? And if it's not in the chest, what about in the lungs? What about in his GI system? And see how many of the differentials you can come up with if we say, okay, let's talk about what GI signs and symptoms could be present, what kinds of underlying conditions could be there. And so our next slide will show what other possibilities that are non-cardiac. It might just be that, he's out playing golf, but was he shoveling, or was he chopping wood? Did he get a costochondritis? Did he have some trauma to his chest wall? Could this be an early herpes zoster, a shingles, that you get pain before you get the rash? And then always a diagnosis of exclusion is, could this be related to anxiety or underlying depression? And so we want to be very clear in how we want to, just because a test exists doesn't mean we have to do the test. So what are the basic labs? What are the basic things that we want to do? A chest x-ray is absolutely in order. And what are the findings for if you have a wide mediastinum? That could be very life-threatening with a dissecting aortic aneurysm. It could be something, a spontaneous pneumothorax, that if it's missed, then that could actually go and cause a tension pneumothorax. And once again, that would be life-threatening. So not everybody would need a resting echocardiogram or echocardiograph, but if you're going to do an echocardiogram, what results or what information could you gather from that? And we know that the EKG can change with time. So now you can say, okay, he's still having pain. This is what his EKG looks like. And you could have that as a discussion point. And then I'm taking the next slides right directly from the slide deck and from the text itself, that you could give a nice overview of acute coronary syndrome. And the first bullets are going to be really important bullets. Like, these are take-home messages that if you were asleep throughout the whole other discussion, these are the things that you really need to think about. And then it goes further into acute coronary syndrome and how do you manage this, and why is PCI more effective than giving a fibrolytics? And another take-home point is only fibrolytics can be used for STEMIs, that if you have non-STEMI or you have unstable angina, you actually cause more harm than good. And those are points that you could really drive in whenever you're giving and whenever you're working with your students on these discussions. And then, of course, if they survive their acute coronary syndrome, what do you do for long-term treatment? What are the roles? And this would be a nice pharmacotherapeutic area to discuss. And it's bringing in other treatments. And of course, you don't want to think about or forget about lifestyle modifications that are always part of the long-term treatment. But all of these slides are coming directly from the textbook So there's a lot of richness that you can use and expand upon depending on your audience. How early are they in the program? What have they learned so far? And so if you're familiar with those things, you can really move forward and really make this a challenge for the students. You can go to the next slide. And my colleague Stephanie Neary is up now.
All right. Hi, everyone. So I took this in a kind of overlapping in some of the ways that we're presenting it, but in a slightly different angle here as well. And I think our hope is just to show you that there are many ways that you can take these cases. So this case also came from the faculty materials that are associated with the book. And so you could simply give students, that piece of paper with that information, or you can walk them through it in a live scenario where you have different students, you present this case and you would have students in your audience trying to chime in and fill in this differential. And then once we see our differential here, we would be able to break down these in the class. So at this point, you could have your class each talk about these as a whole, or you can break them out into smaller breakout groups, which we do in Zoom quite a bit with our online students, and say, all right, group one, you're going to talk about the first one here on our differential. Group two, you're going to talk about the second one. And then, we come back together and we present those. So with this patient here, we have our 24-year-old female who presents with vaginal discharge for 4 days. We came up with quite a few different things on our differential diagnosis. And then it's going to be time to get that history from your class. So when we get that history, again, you can just give that block history and talk about it. Or you can have your students at that point say, all right, somebody, what's your first history question? And go through from your students to start to fill in that history and answer those questions either on behalf of the patient, or as Chris was saying with hers, you can also play that patient. We do that quite a bit with our students, and it's actually a lot of fun to take on the roles of the patient sometimes and to answer those questions and really get into that dialogue with your students. So in this short HPI, we can see some really key things here. We see that there is no prior symptoms associated with this. We see that characteristic of the discharge, which is thin and watery, and then those associated symptoms, which are going to help us when we go over the review here. We'll see how those kind of play into our differential. Other things with our patient's history here, we saw that she has no known drug allergies. She is on that oral contraceptive, which should spark a different conversation about contraceptive use and barrier methods versus hormonal methods of contraception. So you would be able to incorporate that into a discussion, either for right now in the classroom setting, or you take that as a takeaway, for your students to research and to come back and talk about the next time, which is something we use a lot for our students as well. And then we see our social history, which is really important here. And each one of these things you can dive into farther, given your time constraints, to see, how does this play into the scenario? And if we changed one of these things, would it alter your differential at all? So being able to tie each one of these pieces of history back to our differential diagnosis, and why did we ask that? Why is that pertinent? If it were different, would that shift the order of the things on our differential diagnosis? Once we establish that history and we've talked about all the different differentials and we know that we want to proceed with our physical exam, we would be able to get that information, and we see that our patient here, vitals are pretty normal, but our patient, we know she's well-developed, well-nourished, white female who appears her stated age. And then what physical exam things are we wanting to perform? This patient, we're probably not going to do a full comprehensive physical exam on this patient. So the key things that we want to make sure that we get really for her is going to be the external genital exam or the skin exam there. We note no rashes or lesions. And then that abdomen, pelvic, and rectal exam for this patient. Each one of these can be broken down farther for discussion with your students as well. And like I said, sometimes we put students into groups so that they do them that way and then come back and say, okay, what did you do and why did you do that? How did that differ from what group B did and why they did that as well, to make it more of that interactive discussion. But this information with these responses under here does come from that faculty materials. So you would get this case with the questions, these follow-up questions that I'm posing to you guys are the questions that are posed to students, and the descriptions that I'm giving are actually descriptions that are included in that facilitator guide as well, so that you would be able to disseminate this to your faculty if you were doing small groups, and you could actually work through a uniform case that way and lead that discussion without having to have every person be a complete subject matter expert on every case there. So once we establish that physical exam, this one really lends itself to a great discussion about laboratory studies and the findings that we may see there. So we find out from our case here that we've performed in the office our wet mount and our KOH prep. Again, we'll talk about those in our review, but you can divide those out and why and what you may find. And then our pending results. So once we have our pending results for our GC chlamydia and our HIV test, we can go to the next one here. And reevaluate those differentials. As Jim said, now that we get this additional information, how do we take that back with our students and say, okay, but remember you had this really broad differential at the beginning. Now we got more information. How are we going to hone this in? Does it shift the order? Do things move up or down is what I always tell my students, right? We had this list, what's moving up, what's moving down. Is there anything that we can rule out completely here with the results that we have? So once we establish our leading differential, we can say that based on our physical exam, based on these existing lab results, we want to say, what are we going to do to treat this patient? We had many different things with many different treatment options on our differential there. But for this patient specifically, that cervical motion tenderness, that red friable cervix, the thin vaginal discharge makes it most likely to be chlamydia or gonorrhea. So our treatment for choice for that is going to be our doxycycline and our ceftriaxone. But I think it's important, and one of the things that we include in a lot of these cases is they don't just stop with here's our medication management, right? We know that we're going to prescribe that medication and we can memorize, you know, for this condition, we're going to treat it here. But there's a much larger discussion that goes into play when we're managing and treating our patients. And patient education is going to be a really big part of that. So our cases also bring in a lot of this information from that patient education piece of things and say, now that we've prescribed this medication, what are the other things we're going to talk to our patient about here, right? We have a 24-year-old female who's sexually active, who has multiple partners, who's not using barrier contraceptive. What else are we going to talk to her about? So we need to talk about in the immediate, which is going to be abstaining from sexual activity for 7 days after it concludes. We know that we need to also treat her partner, but also what are the other things just for general prevention that we need to be talking to our patient about and getting students to think about those. For these, I love to flip it back to the student and say, okay, I'm your patient, now educate me, right? Tell me all the things that I need to know to walk out of here, you know, holding that information to do something differently next time, to improve my practice and whatever it is, and to move forward. So we can go to our next slide here. And then the long-term prognosis for our patient. So making sure that we know that this works really well for her when taken properly. And then what are some of those complications we need to make sure we are looking for? So anytime we have that vaginal discharge and we have the diagnosis or the presumed diagnosis of chlamydia or gonorrhea, we absolutely need to be thinking about pelvic inflammatory disease. And this opens up that whole separate conversation for what are those risk factors there? What are the different presenting signs and symptoms that we may see? And for some of those, it's going to be overlapping, like the cervical motion tenderness and that red friable cervix. However, we would see other things with that diagnosis of PID, where we'd have fever, we'd have probably more severe pelvic pain, adnexal pain, that right upper quadrant tenderness that we may see with the perihepatitis there as well. And then from our next slide here, you can take that case, and once you've had this really rich discussion where you've kind of brought this back to the students and we said, okay, we've talked about all these different things and we've had all of their different input to get through this case together, either in small groups or the class as a whole, you can do now, okay, our overview. So sometimes I like to use things like this, where these slides and these pictures came right out of our faculty resources slide decks and the images in the textbook chapter as well. But you could also not fill in this chart and just have our types of vaginitis and then their associated features. That becomes a classroom activity also. Say, all right, let's fill this in. You know, this is an empty box. What are we going to include in here? What are your big takeaways? As Chris was saying, if you slept through everything else, if you forgot everything else we talked about, what are the things that have to go in this box that leaving you here, you know, you have to remember that are associated? And so we've put together these charts, but you could also remove those off when you're giving this lecture and make your students fill those in for you as their really big key takeaways. So we have one that shows here, we would talk about our physical exam and what we would want to make sure we would do with every patient who comes in, and some of those key characteristics that we may be looking for, and as well as any pathognomonic features that we may see. The same thing, we can break down our differentials the same way in chart form, and we include a lot of these throughout the faculty resources for these things in the slide decks, but also in the textbook chapters for the students as well, really looking at those key differentiating features. This slide here in particular is one of those things when it comes to high yield for teaching, high yield for pants, high yield for clinical practice, you know, knowing these differentiations and these features, especially with a topic like vaginal discharge, for what's going to happen with the pH, what are we going to see on wet prep and what other studies are going to be indicated. You can then have students expand this out even farther and say, okay, now what are we going to do for treatment on the end here? Or what patient education do we need to know? And, you can extend those out farther on those charts as well. And then doing a nice wrap up and saying, here were all these different things that were on our differential. So here are all the different ways that we're going to treat them. Now, if you were going to bridge this into, if you're doing like an organ systems based program and you wanted to bridge this into a further discussion for your pharmacology class, this could be your springboard to say, okay, now we're going to shift gears. We're going to talk about all these different medication classes and then shift that into more of, a pharmacology discussion or something like that, but able to bring together all of the different courses through these cases as well. I think that was it for this one. Yeah, so we want to open it up to any questions that the group has. I think we had a few as well.
Yep, I'm going to get started here again. This is John coming on back. I do have a few questions for the group, but first of all, I just wanted to say thank you. Thanks to Jim and Stephanie and Christine for not only taking time out of their schedules, which right now I know, we're almost to the end of the semester. I'm sure time is extremely valuable right now, but also just presenting this for us, taking the time to put these slides together. So thank you very much. And thanks for everyone who has tuned in today to listen to our presentation. So getting to the questions, the first one, and maybe Jim would want to speak to this. This is someone who's starting a new program and they're getting started with developing a clinical medicine course. So how would you recommend beginning that process, and really how would the book help with that?
Great question. Something I've done twice now. Just recently, 5 years ago, starting the online program. I think one of the, and Chris has started a new program as well. So when we were looking at developing this book and how to utilize it, how faculty could utilize it, how programs could utilize it, how students could utilize it, we wanted to make it more than just a textbook of content. We wanted to make it a resource-rich book. We've gone through some of the cases. We haven't shown you any of the test item bank items, but there's over 1,000 of those. They can read the textbook. There's the PowerPoint slides. But as you can see with the cases, with the slides, with the book, with the questions, what we've done is we've given faculty multiple opportunities and different ways to utilize this. Whether you want to use it in a team-based learning atmosphere, you want to use it in a problem-based learning atmosphere, you want to use it with a large group of students maybe you have 50 students in the class, and you have one faculty member who has to drive this with 50 students, it can work that way. You can take those 50 students and divide them up into smaller groups. You can use these cases and provide them with the questions, but not the answers, and they can go through this on their own time outside of class. We do that a lot. We call them paper cases at the Yale Online program, where the students then work through them on their own and have these detailed questions that they have to answer. So the sky's really the limit here on the opportunities and the way you can connect this. As Stephanie mentioned, you can use this to connect the clinical medicine to the pharmacology. You can use this to connect the physical assessment or physical exam courses to the clinical medicine. The diagnostic studies or laboratory medicine course you have to the clinical medicine. Most programs have clinical medicine as their big course, let's say, it's the big credit course. It's what everything revolves around. Using this book and using these resources helps you and helps the student, more importantly, show the connections on how this material is connected back to clinical medicine. And it's a great segue. You could use one of these cases like the one Steph just did, and that could be your theme for the whole week, where in clinical medicine, you're doing the lectures on these sexually transmitted diseases, and maybe pharmacology at the end of the week is a lecture on the treatment of STIs. So the sky's really, the only limitation to utilizing these materials is your imagination on how you could utilize these, because there's so many different ways to do it. And I'm sure we did not even think of half of the different ways that you could utilize these materials. So, and that gives the programs a lot of flexibility. Not everyone wants to do team-based learning. Not everyone wants to do problem-based learning, but these cases, these institutional and instructor resources are so rich and to be used in so many different ways that you can still develop. So as you're trying to think through as a new program how you want to deliver content, there's so many different ways you can use this information and these resources that the sky will really be the limit. The only limit will be your imagination. Now I sound like Disney. The only limit will be your imagination.
This is kind of like Disney, Jim, except without the mice and ducks.
That's true. Yeah.
Justine, did you want to add anything? Because Jim had mentioned that you had started a program as well. So
Yeah,
anything-
I've started two programs, but 26 years apart from each other. So a little bit of change in the educational process.
Just a little.
But I'm a very big team-based learning proponent where there's exercises, assignments done ahead of time. And I think the chapter assignment for reading would be a really nice way as a segue to use these cases to apply the knowledge, because I think knowledge without application is not appropriate. And I think application, you can't apply what you don't know. So I think you need to have a foundation of knowledge for you to be able to think clinically and critically. And that's another area that I think the cases are going to help develop clinical reasoning skills. And the ARC, of course, wants to see how you're demonstrating the development of critical thinking and critical reasoning skills, and using the cases as an add-on to the material that is in the book itself could be a very good way of showing that you're demonstrating the development of these critical things that students have to have. And that's what makes them successful in their clinical arena. But you also need to get that foundation of knowledge, which I think this book is going to do. What you don't see in the book itself, but you will see on the online resource, are the thousands of references that are utilized in the book. These are not people writing the text, and we use so many outside experts to help with the entire book collection. And you'll see that the hundreds of people that did add to the richness of this book. But what you're not seeing, but you will see on the resources, are the references. And so it might be that you're reading about something and saying, wow, I really didn't know that. Let me go back to that reference. You can go and, as a faculty member, deepen your knowledge to understand things to a deeper level. And the references are right there in the online version. They're not included in the textbook because the textbook would have grown by several hundred pages. And so all of that, this is not just people being, oh, I'm an expert, I'm going to tell you everything I know. These are people that are referencing, and this is as current as it can be. And you can go back, if you disagree with something that's in the book, it's going to be referenced. And then you'll be able to say, wow, this is something I really learned, and I didn't know it. And I've been a PA a long time. If I didn't know it, other people don't know it, and I want my students to know it. So I think the resource can really be a jump off point, and you can go and research other things based on the references that we've used throughout the book.
Thanks, Christine. That was really great. I appreciate that. I do have another question coming in here, and this has to do with a scenario. So, of course, all of you have students that are perfect. They get 100% on every test, and they do perfectly. But there are times when students struggle, and they have difficulty with whether it's test bank questions or just the course content. So, what remediation strategies would you recommend? Anyone could take this one. So I know Steph
I could.
has a lot. You want to take
Go
that?
ahead, Steph.
You have to.
If you were going to jump in, you can go ahead and then I can piggyback on it.
Okay.
Yeah.
So each of the questions that are in the test bank, you could easily write a learning outcome from that question and identify what it was that the student didn't know. And that's why it's really, I utilize a lot of questions for actual learning, because it identifies what the students don't know. So you can put the onus of the learning back onto the student to say, all right, you got a question wrong about heart failure. So the question that you got wrong talked about why you get shortness of breath with mitral stenosis leading to heart failure. How does mitral stenosis lead to congestion and lead to exertional dyspnea? And then you can sit and have the student handwrite. I'm a very big proponent of handwriting rather than copying and pasting the learning outcomes from the questions, and then sit and have a discussion with the patient or with the student. And I think that will really identify what they don't know. And it's not that difficult to write learning outcomes, because each of the questions does have an intended learning outcome. And I think that's the gist of what the student should have taken away. and put the onus back on the student. But that's a really good starting point.
Yeah, and I would say we use a lot of oral exams for the same kind of reasons, like you were saying, to have the conversation. Can you talk through this information? And I think you could take these different cases or questions and you can put them into questions that you would ask in an oral exam type situation as well. So if you had a student who was struggling in the reproductive section, pulling that one just because that's where my little vignette thing here was from. But if we had that and we said, okay, now we're going to talk through this. Did the student primarily struggle in their diagnostic studies one? Let's have it. Here's your case scenario. Let's break that apart and have that full blown conversation, you and I, about all of these different pathways and why we chose one test over another test and what they might show us. And you can work through all of those different kind of trails with your student to make sure you get to their endpoint of learning to see really where they're at. And you could adapt that same case if it was more of a pharmacology driven remediation. You can have that case and you can talk through all of them there.
And to piggyback onto that idea, I've used these in the clinical year as well, where the students are out on rotation, where they should be putting all of these things together, not just focusing on pharmacology or diagnostic studies, but where the students are trying to put the whole thing together, where maybe they didn't do great on an end of rotation exam. And you sit down with them after they've done some remediation in the areas you've identified that they struggled with the most, and you can actually utilize these cases to help have them talk you through, and you get the chance of asking them, well, why did you do that? So it's a much deeper way of remediating a student other than just giving them another multiple choice exam to remediate and see if they can score above your cutoff. This allows you to really get to the depth. So maybe a student would have gotten your question wrong that you wrote on remediation exam about vaginal discharge because they didn't know that one piece of information, but they knew 95% of the rest of information, just not happen to be the piece you tested on. Here's a chance, we're using these cases for you to investigate their entire knowledge instead of just focusing on one area, one question. And I think that's an issue that a lot of programs have with doing remediation. We will, and I've did it for years before this way as well, or just throw another exam at them because that's easy. We'll just take items from the item bank and we'll put another 50 question or 60 question exam together and they'll take that. And then I know if they pass, they successfully remediated. Maybe, maybe not. Maybe they got lucky and the 50 questions you asked were the 50 things they studied out of the 100 you gave them. Really wanting to know if they have the depth of knowledge to apply. I have yet to have a patient come to me in clinical practice where it said A, B, C, D, E on their forehead, and I had to pick which one was correct. You have to apply the material and come up with solutions and plans and things. So having the students do, if we really want to make sure the students can do what we want them to do as clinicians when they're done, we should really test them and evaluate them the way we want them to utilize the material. I know multiple choice exams are the easiest route to go. It's the least work. It's the standardized thing, but I'm not really guaranteed or sure myself to say, boy, my exams, when they pass them all, do I really feel, yeah, they probably have the minimum competency, like the boards, but I'm not sure I'm happy as a program director with minimum competency.
Right. Well, I got one more question for you guys, and this has to do with our favorite topic of accreditation. So the question is, our curriculum must include instruction related to the development of clinical reasoning and problem-solving abilities. So how would the book help with this sort of area of accreditation?
Chris hit on it already. This is what these cases do. It's what we showed you in the 3 scenarios we gave you, that we went through, is how, whether as a group, as an individual student, as a small group, a large group, you're actually having the students apply. And I agree with Chris in that to some extent, you have to have some fundamental, I know people are going to roll over now that I agreed with Chris, but you have to have some fundamental knowledge to build on. It may not be all the knowledge you need, but there has to be a building block. There has to be a starting block. For most programs, we count that as prerequisites, that to get into PA school, we expect them to know some basic things, and we build on that. And that's what these cases allow you to do. And as they work through these questions, like I said, I've used them where they can take the questions and work on them themselves. They can work on them in small groups. You can lead them through this. When you lead them through this and the way the cases are laid out, they lay out and give them information as they go through. Now, students can always skip ahead and look ahead at them, it's like reading the end of the book. or telling people the end of the movie. Nobody wants that. They want to be able to solve the problem. In these cases, the way they're laid out, force the student to apply the material to come up with a differential, ask what they want to ask, get some information, revisit the differential, get some more information, revisit the differential, get some more information, revisit the differential, come up with a diagnosis, and then a plan. So it forces them to do that thinking and that reasoning and application all the way through. And they can use the book as the resource to find answers to those questions. They can use other outside resources. They can use our reference list from the online version. So it's a really good way to prove to the ARC. I think it's, I can't remember, is it B 2.03 or something like that? Boy, if that's correct, I am really sad in life that I've got those memorized. I don't think that's the right one though. But this is a really good way to show the ARC that you're doing these cases. And the beauty of it is you don't have to create them from scratch. The questions are all there. And more importantly, the answers are all there. So if you're not an expert in chest pain, or you're not an expert in vaginal discharge, or you're not an expert in anemia, the information, the answers are all there for you, so that we've taken kind of the heavy lift out for the faculty to have to do that. So these are definitely a way to show the ARC that you're doing the clinical thinking and diagnostic thinking and reasoning with the students through these cases.
Great, thanks, Jim. Could you hit next slide for me, please?
Sure.
All right, so this ends the question and answer period. Just wanted to know, a little reminder here, today's event was recorded and will be posted on springerpub.com/videos in 7 business days. If you're registered for this webinar, you will receive an email with a link to the recording as soon as it's available. Now, the last thing I do want to mention to you is if you're interested in purchasing the presenter's book, Clinical Medicine for Physical Assistants, we're offering a 25% discount for attendees today. So go to springerpub.com and enter discount code webinar25, that's webinar25 at checkout. For additional information about Springer Publishing products, visit us at www.springerpub.com. Thank you again for attending today's events. Thank you for the presenters. We hope to see everyone at a future Springer Publishing webinar. Stay safe. Bye, everyone.
Okay, thank you. Thanks, everybody.
Thank you.
Thank you.
you.